I will take the opportunity to give you feedback on the question we sent to the audience. In fact, when we talk about personalized medicine, as you mentioned, we talk about mainly about genomics information. So we asked the audience, have you already your genome sequenced? And in fact, 96% responded with no. So maybe there's even also still a need to get information. So we are still at the time point of collection, at least, let's say, maybe in the countries that are mainly participating currently in this conference. Then we asked if the audience would be willing to share the information. And then the question for that was yes, and to whom they would like to share it is mainly to the medical team and the doctors. And after to public research organizations, but much less to, and not at all, for profit research organizations. Not exactly. So, and the last question was, I think, exactly, what is the most promising use of data for personalized medicine application? And here the feedback from the majority is that this is for them treatment decision making. So mainly, I think we are still having a focus on the patient, although I can see that prevention is already on the second place. But still, we are thinking a lot about the patient when we are thinking about personalized medicine.
So what we are going to do is to go directly to the panel discussion. For that, I will first introduce the two additional panelists that will go together with Søren and Peter into the panel discussion. The first one is Barbara Prainsack, that was already speaking in the previous session. She's in the Department of Political Science at the University of Vienna. She's the director of the Center of Study of Contemporary Solidarity and the Interdisciplinary Research Platform for Governance and Digital Practice. Is in a number of committees that I'm not going to read, including all of them, the Austrian National Bioethics Committee and the European Group on Ethics in Science and New Technologies, advising the European Commission that is, I would say, very relevant for all these problems with data that we are discussing this afternoon. Barbara, maybe you want to start with some initial propositions.
Thank you very much, Alfonso. I thought you would introduce Ernst first, but I can kick off with some thoughts that I had just very briefly before we go into a discussion. I thought that both talks were really important and illustrated the importance not only of data sharing. I will say something about the terminology of data sharing in a moment, but also of good data governance. And there is a large study going on, a global study. For those of us and for those colleagues in the audience who've been part of the previous session, it was already mentioned. It's led by Anna Middleton in Cambridge. It's called Your DNA USA. It looks at data from over 36,000 people in 22 countries in 15 languages on how people want their data to be used. And overall, it depends on whether we want to focus on the good news or on the bad news. The good news is that people are generally happy to make the data available for others, to others, if they feel that some fair benefits are being achieved, not necessarily for themselves, but for other people. So fairness is a very important thing. Trust is a very important thing. Trust in good governance is a very important thing. The bad news is that there's still lots of people who are not willing to share, to make the data available to neither their own doctors or commercial companies, which probably reflects something that I would call a vacuum of trustworthiness. I wouldn't call it a vacuum of trust, but trustworthiness. So sometimes data users have yet to establish that they are actually trustworthy, that they are discussing with people at eye level. And one important thing with which I would like to conclude my sort of opening input is that for a long time we have considered data protection in the form of increasing individual control over the use of individual data. And that's for very, very good reasons. And that has been very, very important as well. The General Data Protection Regulation in the UK is a manifestation of that, but also other solutions. But what becomes increasingly obvious to us is that that's not enough, that what a lot of people want is also stronger collective control and oversight over data. So not replacing individual control, but complementing individual control. So what do I mean by collective responsibility and oversight? Sometimes when there are very problematic uses of data, then maybe there's a need for law to step in. And I'm thinking of a lot of the things that we're discussing with Google and Amazon and so on. So sometimes we throw our hands in the air and say that this is all very unethical, but if it's so unethical, why allow it, right? Whereas a lot of the research that goes on for public benefit, or that could take place for public benefit by research institutions, can proceed only much more slowly because there's a lot of ethical governance requirements and so on and so on. So maybe the balance is not always right. And this is also a moment where we see the need for more collective discussion, but also regulation and collective decision making for how the data of the people are being used. And there's also maybe a reason to consider ownership also in terms of a collective societal ownership that means that some people have individual control over how their data are used, but we as a society need to have responsibility for using data in a good way that benefits other people, and also to support people when something goes wrong. So one of the things that colleagues and I have been promoting is actually that we think about harm mitigation in a much more explicit and structured way, because where there are benefits, there will also be some harms, and I think we just need to speak about them very openly. So my plea is for, and some of us in this round have had fantastic ideas also to increase collective forms of ownerships and responsibility, but good data governance needs control and say from individuals, but it also needs much more control and responsibility from societies as a whole. It's not something that can be left to individual people or to professional experts.
Thank you. I think quite a lot to discuss. The second invited speaker on this panel discussion is Ernst Hafen from the ETH in Zurich. He's obviously very much related with biotechnology industries. He's the president of the Biotechno Park. And interestingly enough, and he may tell us more about that, he's a founding member of a company that is specialized in data privacy, personally owned data, citizen-owned data for the management and control of their own information. That I guess goes directly in line with the previous discussion. Please, Ernst, can you introduce?
Yes, Alfonso, thank you very much. I hope you can hear me, and thanks for all the panelists. And I just heard a second half of Søren's talk also, and I'd like to just connect where Søren left off. And my take-home message there is that more and more data is available, more and more data comes from smartphones, from sensors that is highly relevant from cradle to grave. And so we have the machine learning tools. Barbara mentioned that we have come quite a way in discussing governance of data and accessibility of data. And that is clearly important. For the last 15 years, I've been promoting the fact that we should go to a citizen-centered control of data, because personal data can be copied, and GDPR gives each person a right to get a copy of the data, from shopping to clinical to genome, smartphone data, etc. And data is an asset that's equally distributed amongst individuals. We're all billionaires in genome data, whether we live in Ghana or in Switzerland. And thirdly, we as individuals are the maximal aggregators of this data. So I've been promoting and been co-founding the idea of data cooperatives, not just companies, but cooperatives that have individual citizen ownership. And we've built examples of these cooperatives like medata.coop. And after 15 years of doing this, I have to tell you, it's not working. It's simply not working, because people don't simply care about ownership alone. They want to have a personal benefit. And this is not money, as Barbara said, but they want to get something back. We have, in order to change this, I think we need two things. We need to make it beneficial for the individual, and for different patients this is different. But 14 years ago the iPhone was introduced, and there was never a parliamentary discussion whether we should allow iPhones. And everyone in the world has an iPhone or a smartphone. There are more smartphones than toothbrushes. Why? Because there is personal utility. And so we have to go through this personal utility for patients, but for healthy individuals that want to lose weight, etc. And then we say, and by the way, would you enter this data into a data commons? So I'm talking about the data commons where people agree to share all their data anonymously, and that these commons are then controlled by data cooperatives or even for-profit companies where people can have ownership, and they get, in the long term, in the short term, they get something for their own immediate needs as patients, as mothers that have babies that may feel depressed, etc. And in the long run, they profit from having their data being shared in these data commons. So I think it needs these two different things. And I will end with an example of how difficult this is. And many of you will know the company Flatiron, which is a company that basically just collected 2 million hospital records from cancer patients from 270 cancer centers in the US, where you can do that. They had a financing round. The last financing round was 250 million to just structure these hospital records, and they have 500 people. In 2018, they were bought by Roche for $2.1 billion. So if we want to have fair companies, not Flatiron, but data cooperatives, we have to finance them in a similar order in order to structure and make interoperable smartphone data plus clinical data plus genome data in data commons. And we have to raise this money. We have to do that. Otherwise, we're going to talk for 15 years about personalized medicine in Europe, and we have data silos after data silos. We have white papers on data governance, and we have little data cooperatives. We have maybe $1.5 million raised in the data cooperative, and it has 15,000 accounts. And some have 3 entries in a pollen app, and the other one has 3 entries in a corona science app. But we have to empower these cooperatives to collect the data as fiduciaries of the individuals who agree to that. And otherwise, I don't see any hope for Europe to get out of either surveillance capitalism in the United States or the state surveillance that we see in China. And they are far ahead of us, obviously.
Søren, please.
Yeah, at least I can comment maybe also from the Nordic perspective, because there and it's not only in the Nordic countries, but at least we've had some kind of commons in the form of these national registries for years, and that is at least a model where a lot of data is captured, even if ontology is changed and so on, and also in a population-wide manner. So at least it takes care of some of the problems you mentioned, Ernst. And I also acknowledge that this is, of course, easier in smaller countries. But I made this point that we are not good at taking data from one patient in these registries and then using these data in the treatment of that patient. And I think that's a big problem we have, because there's a lot of predictive value for the patient in actually using the diagnosis history or the prescription history and so on. And I think we should be better at actually giving something back to a single patient. We are good at computing averages and doing classical epidemiology and maybe also using machine learning and all that. But we should also give something back to single patients in a more individualized way. At least I think that would be a good possibilities in many cases.
Thank you. I want to just to follow with this discussion in a general sense. I have maybe we can go around, and I can ask you can get your opinion about what you see as the main practical problem, the main roadblock on all this area. What is the kind of thing that you will solve that is not in a practical sense? Because we are discussing different levels here, no? From very general organizational, social issues. But what do you see as the key thing that we in Europe, but in general, will have to solve to really move ahead with these access and integration of data that we see as a real problem?
I guess if I should go first, very short, I would say regional data protectionism. I think that's a huge problem, actually, in small countries and in large countries. But there are also some exceptions, and not very nice exceptions also in the COVID-19 area and so on in Europe recently. But most countries have organized their healthcare in regions, and it's interesting that when it comes to the deep data, not just the registry data that I showed with diagnosis and prescriptions, but when it comes to the deep the data, then there's a lot of fighting between the regions, and the regions keep the data to themselves because they want to exploit them. And this is also a link to what Ernst mentioned with this company, Flatiron, that actually had some deep data, and then that became very valuable. So I think regional data protectionism around deep data, I think this is where we need to solve some of these problems so that we can get more health-related research out of these data to the benefit of the patients.
Other opinions?
Yeah, I had my hand up, if I can.
Please go.
So I think what Søren just mentioned about regional data protectionism is a really, really important point. We could go in two different directions and think about the main roadblocks here. So one is clearly interoperability in a technical sense, but also in a social sense. So we have to solve a lot of interoperability problems before any vision of precision medicine with the inclusion of multi-omic datasets and longitudinal datasets can become a reality. Again, not only interoperability is not only technical, but it also has a lot to do with people understanding what actually the social value and the meaning is, and agreeing on what the value and meaning is. This is a social interoperability problem that Gina Neff calls attention to. But regional protectionism could also be mitigated by removing a very frequent excuse for why data are not shared, which is data protection. So sometimes data protection, sometimes data aren't shared because there are very real and serious data protection issues, but sometimes it's a claim that is used as an excuse for to keep data within silos, to keep it within your institution, also to not be liable. So the stakes are wrong. Institutions, and especially within public healthcare systems, feel the need, and rightly so, to reduce risk because they don't want the reputational and financial and other damage of something going wrong, but they don't have a stake in the benefits that could be achieved if data were shared more broadly. So what does this mean? I'm coming back to my idea and my notion of harm mitigation. So we have been promoting for a number of years now the introduction of harm mitigation bodies, which I don't want to go into this in detail, and if anyone is interested, we published it, but harm mitigation bodies would first, there would be an addition to legal remedies for people who don't have access to legal remedies because they don't really know what caused the harm and so on, and they're not sure what act or omission was causal to the harm, but people who feel that something went wrong in how the data were used. There needs to be a body that takes the risk away from the data processor. If it's a hospital, if it's a public institution, if it's an entity that really works for the public benefit, and an entity that people can apply to. They can sometimes just feed back what didn't go well. Sometimes they can get an excuse, somebody who owns the problem and says, we're sorry. Sometimes that can go a long way. And in cases where people have suffered financial harms, the harm mitigation bodies could also pay out support. This is not restitution in the legal sense, but it's financial support. So I think as long as we have the stakes, we haven't figured out the stakes of the decision makers on data sharing, and it's often not the patient, it's not the research participants, it's the organization the data controller very often. As long as the stakes don't change there, as long as the incentives and the costs and the benefits do not change, the notion of regional data protectionism that Søren mentioned will not change. And in order to get there, we need to think about harm mitigation as well. We have to shift the risk so that the benefits can actually accrue, and that people who do experience harm are not left alone.
Yep, very good point. Any more comments on that? Do you have your favorite problem, Peter?
Yeah, I just say, well, first of all, when Søren was presenting after mine, I thought this is that incredible rich gold mine of potential win if we can bring the genomic data, the omic data generally, and match it and marry it with that health data. If we can do that, then we'll know in 5 years what would otherwise take 20 years using traditional research silo thinking. But so I have congratulations to showing it in that way. And I think the fact that national health systems had a different position, a different level of integration is something that I was just going to expand on, because I'm based in Canada. I have this global responsibility, but I'm based in Canada. And as we're trying to do some of these things here, which both give clinical value to an undiagnosed rare disease patient, and at the same time make that data available for research use globally, we're having to do it province by province and institution by institution. We can't do it at Canadian level. So what we do in Ontario is not what we do in British Columbia. We have to build it up. But actually, when we dig deep, it's not even at the state or the province level. It's not organized well there. It goes right down to the individual clinician holding a piece of data on a patient, and in a different hospital or a different setting, a different system holding information on the same patient, and the patient not even being able to assemble the knowledge around themselves. Sometimes they're told, I can't share it for privacy reasons, even though it's the data about that patient. So I think as Ernst was presenting that, can we make those co-op approaches work, this shared ownership? I find in many places people want the health system to take care of them in a very comprehensive way. They want other people to be good stewards of their data. They don't want people ever to misuse their health data. But personally, they don't want to have the responsibility for owning and sharing all their data. So we've seen experiments after experiments of trying to give all the control to the patient, and then that fails. So finding this balance between meaningful information at an individual patient level and global understanding that we can all learn from, as we're trying to do with COVID, I think there's an incredible difficulty. And it's because of the way healthcare has been built over many decades in almost every country we experience. The healthcare system is incredibly local.
Please. We cannot hear you.
Okay, yes,
Yeah.
sorry. Stress again the personal usage of the data, and I fully agree with Peter that most people are overwhelmed with having to control their health data. And my example recently is that I'm overwhelmed with controlling my financial assets during my impending pension. And so my wife said, let's go to one of those, banks and we went there, and they said, well, it costs 3,000 Swiss francs and we'll analyze everything and we make a plan for you, So they basically collected all our financial data from tax returns and accounts and so on. And we were so happy to pay 3,500 francs. So to get to say, you're safe, you're going to have money in 20 years from now. And that's exactly what we need for health data as well. Have a fiduciary role like a bank, and this could be a cooperative, that then actively we may actually pay for them, or the government may pay, go and collect all the data, the omics data from 23andMe, the clinical data from the university hospital, my Apple Health data, puts them together like a flat iron, and then a data commons exists that will generate revenue. Roche will want to access this, and it will pay billions, but it's under the control of the individual, but it transfers the control to a trusted fiduciary. And then Barbara is right, then this fiduciary must not misuse the data, and if it does, then there has to be mitigation, right? Very good. But first we have to put it into the decision into the hands of the individual.
This, to me, this brings us to the problem of balance, and maybe you want to comment on this. The balance that was already mentioned between what the technology can do and what the social structure of convincing governments, people, institutions can do. I guess we have to find the right balance between what technology can do, and we know that technology can do more and more things every day. At the same time, this has to be in parallel and in balance with the social, ethical, and legal framework. So how do you see this balance between technology and the non-technological part that we need to be able to achieve this access to data? Who wants to start? Søren?
Yeah, I can maybe start by also mention the word inequality, because you talk about balance, about technological solutions, and then the right of the individual, and these are really important aspects that have to go together. But of course, at least in our societies, I mean, those who maybe are not in a good position to manage their own data, they may be the ones who are most in need of treatment, and also decisions around how their data should be used. So that should also be considered. I mean, how do we empower people? But of course, when we get old and get all these multimorbidities on top of each other, I mean, we will increasingly lose our ability to make these decisions, and that needs to be put in so that it's not just the most wealthy part of the population and the most well-educated and so on, those with family and so on, also well-educated, that can use these new opportunities. I think it's very important to have a social angle on this and an equality angle at the same time when we consider the individual's right to decide.
Mm-hmm. Barbara, please.
Thank you. I want to make one qualification to how Ernst understood what I said about harm mitigation. I do not suggest that harm mitigation happens when anyone misuses data. I'm talking specifically about the cases that happen when nobody deliberately misuses data, but the use of data can also create harms. But that's a minor point. What I wanted to say now, apropos of Søren, is that the inequality is, of course, the elephant in the room. And why is it the elephant in the room? Because in Europe, we do not have these horrible, stark inequalities that exist in other parts of the world, but we're getting there. So poverty is not something that happens in the global south. Poverty, especially now with COVID, is something that happens within our own societies. And I think Ernst's example about the financial assets is a fantastic one, but it also illustrates the challenge for our society. So Ernst said that you and your wife, Ernst, you paid 3,500 Swiss francs for someone to do the data analysis. And I fully agree, this is what we need increasingly with data. As we said in the previous session, the cost bottleneck in our healthcare system is not the data generation, not even the data sharing, it's the data interpretation and the translation to what it means for patient populations and individual patients, like the actionability gap, right? So who's going to pay for that? To stick with Ernst's metaphor, who's going to pay the 3,500 Swiss francs for populations that are now underserved? So we have to, when we think about utilizing data for personalized medicine, we have to think about the cost of data interpretation and to ensure that this does not exacerbate existing inequalities, because that's what's going to be the expensive thing. And also one thing that colleagues mentioned in the previous session is that clearly we have to change medical and health curricula. We need to train the young generation now in doing this type of data interpretation work. We cannot just dump it on clinicians and say, you know, you interpret the data and you bring all of this together. So one solution is to create a new profession that sort of, in analogy to genetic counselors, we would have data interpretation or the counselors. But we have to think also of the cost implications of that and to ensure that the inequalities are not on the rise.
Other comments? Peter, Ernst? Who wants to go first? Peter.
Okay, I'll go first since Ernst is still on mute. I would just a quick answer to your comment about technology. I think when we started the Global Alliance, we assumed that there was going to be this explosion in genomic data and that technology will be a barrier. And everything we've learned in the last 7 years is that whatever the scale of the data, the speed, the variety of the data, the big data components, the 3 Bs or the 4 Bs, compute power can keep up with it. Technology is not the rate limiting step. Legacy systems and legacy thinking and people and systems, incentives are the brakes. Technology isn't the brake. But if we use technology well, it can enable the right things, or it can be used as in an inappropriate way. I think some of this anonymized data we're seeing on smartphone tracking of how mobile people are during the pandemic, we saw it we put one area into red, and we see people from that red zone drive 30 miles to the next place, the next town that's still in the open zone. So we could see that from smartphone travel data, but we didn't know who it was. We could see it at a societal level. And I think that technology can do all kinds of things. We just make sure that humans do the right things and put in the right protections and the right incentives so that technology is used wisely. But it's not the barrier or the brake.
Ernst, do you want to?
Yeah, well, I mean, I say it again, everyone, well, equality is a big, but everyone uses WhatsApp and Facebook and Google search, right? Because it is a utility that we've gotten used to use. And I think we have to really break down these different offerings to these sort of easy to use things. And that makes sense for the individual. And then if we have their agreement for such a data commons, then we have what the financial service industry is times 100 in the data service industry, new jobs, new services, etc. that will come. And it may at some point be actually much more efficient also for governance or for the EU to pay these 3,000 francs or something like that for someone to collect the data of individuals that want it, rather than to negotiate about which electronic health record we should have. You know, ours in Switzerland is not even a PDF grave yet. It has been installed in 2016. And now we're discussing about the COVID app. Not even in Denmark, the COVID tracing app has been adopted by a lot of people because there was no utility. If you gave them some personal feedback, it would have been adopted more clearly. And there's always talk about data protection and privacy and so on, but people use WhatsApp and Facebook nevertheless.
There's a very the discussion about what people use and how they see the different levels of privacy is an interesting discussion. We have like 6 minutes, so I want to go to Dan has already been mentioned a number of times, COVID-19 and how this is changing perception, helping or not helping. I mean, we obviously see the difficulties in accessing the data and making analysis. That's COVID has made this very obvious, but also has become a source of opportunity in terms of moving things faster in different areas. So I wonder if we can finish this roundtable with your opinions about what has been wrong in COVID-19 and maybe in a more positive sense, what COVID-19 has helped to speed up things in a number of fronts. Søren?
I could maybe in a little bit provocative way also turn the problem around, because now people are trying to figure out how much worse the treatment of other diseases have become during this period. So we have, of course, seen a lot of very nice data sharing and also data generating initiatives in COVID-19, and it exceeds my expectation also in a sequencing. Denmark used to be a sequencing adverse country, more or less. We were quite late to this, but now it has exploded. But it's interesting that we should not just look at just one disease at a time. Fine for COVID, and of course it's really a special problem that could kill even more people. But we should also have all the other diseases and their treatment factored into this question.
Good point. Still, sorry, do you think that has been helping or not helping to move all these problems of data sharing?
No, I think it has, but in particular, it has helped demonstrating the value of data. Of course, many of these tracing apps and they have also not worked in our country quite badly, actually, but it has demonstrated the value of data. And what I hope is that perception that data can actually be used for all these good purposes, that message has come through in most countries, and of course it should be balanced with the privacy and the data security. But I think actually many people before the COVID-19 crisis doubted that data actually could be used for many of these purposes, and now we've at least seen that has been acknowledged.
But do you have opinions on this one?
It has, I think, shown to many people the value of using personal data for medical and health-related decision making in the broadest sense of the word. It has also made people more aware of how many data they have and what can be done with it. We saw very, very clearly, and Ernst has mentioned the Corona apps. Not only did they not have enough utility in many countries, but we saw very clearly that when people have get the impression that somebody is monitoring or surveying them without it being clear who controls the controllers, that can really create a huge public relations disaster and a decline of trust. So it has, I think, also driven home to anyone who uses data how important it is not only to build trust, but also to build trustworthiness. So overall, I think it has had a positive effect. I mean, clearly we wish that the pandemic hadn't happened, but for data in the healthcare system, I think it has had a positive effect overall.
Peter.
I support the previous 2 points. I think there's also been a health literacy. I think people around the world have got much stronger understanding of several aspects of this. We've heard more about mutations and variants recently on everybody's lips, not always used in the way we might want to use them. We've seen the unfortunate aspects of nationalism, like variants being labeled by country of origin, as opposed to more neutral terminology and used by politicians. We've seen some politicians rise to the occasion and do good things for their communities, and we've seen others do a much less credible job. So I think the other thing that's occurred to me is that many people, and particularly when you look at areas like long-term care in many countries, have realized how massively under-resourced, marginalized populations, lack of health data. And so I just hope that there is enough of a public reaction, political reaction post-pandemic that people say we can't let this happen again in the same way. We have to be prepared. And part of that preparation is having much better data that we can access in real time. So we need to be prepared. My concern is that political timelines and public memories are not long enough to invest in the right solutions.
You're on mute.
Yeah, sorry, I don't need anything to add. I think the previous speakers have summarized it quite well, so I don't need anything to add to this point.
Well, thank you very much. We are exactly on time. I thank the four of you very much for the talks and the opinions. I think there are a lot of things to do, but certainly It's not that we don't have plenty of ideas of things that has to be done. Thanks. Back to the organization. Thank you very much.
Thanks a lot,
for having
Alfonso.
us. Bye-bye.
Yeah. Thanks a lot to everyone in the panel. Thanks a lot for the great discussions. And I think also from this discussion, we got a lot of input, especially also for the next session that is on healthcare systems. And I heard a lot on importance of sharing, ownership, and well, see you back at 5:30 for the next session of this conference. Thanks.